Next up, we've got another rapid fire presentation. This one is entitled Redo Hemodialysis Access in Elderly Patients Has Acceptable Outcomes with Similar Patency of Arteriovenous Fistulas as Compared to Grafts. It's going to be presented by Dr. Weaver on behalf of colleagues. This is a multidisciplinary or multi-center study that includes investigators from University of Florida, Johns Hopkins School of Medicine, and Johns Hopkins Bayview Medical Center.
I would like to thank the Society for allowing me the privilege to present our work. Additionally, I would like to acknowledge and thank our sponsor for abstract submission, Dr. Yingwei Lam. I have nothing to disclose. Identifying the optimal permanent hemodialysis access in elderly end-stage renal disease patients remains challenging. Some studies suggest the decreased catheter time associated with arteriovenous graft placement in this patient population with a high mortality rate favors placement of prosthetic access, while other studies demonstrate improved patency with fewer interventions and longer survival despite increased catheter time in elderly patients receiving arteriovenous fistulas. Choosing the appropriate access for elderly patients requiring redo access in the setting of fistula or graft failure becomes an even more complex decision-making process, and little is known about the outcomes of redo access in this patient population. Here, we sought to describe the outcomes of redo hemodialysis access in elderly patients. We retrospectively identified all patients aged 65 or older at a single institution undergoing hemodialysis access placement between 2016 and 2019. 257 access operations and 211 patients were identified, 116 of which were redo access. Of these, 60 were second attempt, 34 were third attempt, 13 were fourth attempt, and 9 were fifth attempt or greater over a patient's lifetime. Characteristics of the patients are seen here. Primary and redo patients were similar in age and gender and had similar prevalence of comorbid disease. Differences between the two groups included left-sided access placement, which was more common in the initial access placement group, and central venous stenosis and IV drug use, both of which were more common in the redo access group. While 91.5% of the first-time accessees were fistulas, redo accessees were more likely to be prosthetic, with 39 arm grafts and 8 upper and 1 lower extremity hero catheters for a total of 41%. Although bacillic transposition fistulas were the most common autogenous access between the two groups, there were significantly more brachiocephalic and radiocephalic fistulas in the initial access group as compared to redos. Primary patency at 2 years was higher for first-time access than redo access. This was statistically significant. Overall patency was also higher for first-time access than redo access. When comparing autogenous to prosthetic access in the redo group, there was no difference in overall patency at 2 years, with 29.7% of fistulas and 33.6% of grafts patent at 24 months. Of patients with redo access, mean patency was 14.3 months. 51% of redo accessees were patent at 1 year, and 20% remained patent at 3 years. When looking at patients with redo access who are now deceased, 72% had functional access at death. Of those whose access remained patent until death, 77% had autogenous access. On the other hand, most of those whose access failed prior to death had prosthetic access at 60%. 19 patients were lost to follow-up during the study period. Of the remaining living patients, 58% continue to have functionality of their redo access, and over half of these accesses are autogenous, with an average patency of 25.5 months. When looking at those who remain alive and lost function of their redo access, the average length of overall patency in this group was still reasonable at 15.5 months. Overall, 57% of the patients in the redo access group maintained patency until death, loss to follow-up, or study completion. These results demonstrate acceptable outcomes of redo access in elderly patients. When determining the optimal access procedure in this growing patient population, the focus should be placed on a goal of creating an access that will maintain functionality throughout the remaining lifetime of the individual patient. There is no evidence from this study that prosthetic grafts are preferential to arteriovenous fistulas in patients undergoing redo permanent hemodialysis access procedures. Elderly patients with meaningful life expectancy who require redo access should be offered autogenous options when possible, but the ultimate decision for optimal redo access in this patient population is a multifactorial one that must be considered on a case-by-case basis. Thank you.
Excellent presentation on a topic that's both interesting and at times controversial. I can remember at a previous meeting, one of our former presidents, Ruth Bush, rose to the microphone after a series of access cases in elderly Americans was presented and found to have a fairly significant incidence of intraoperative complications, one of which was a death. So with that in mind, what was the incidence of like inpatient hospitalization, intra-op complications, or non-home discharge? Did you have any perioperative complications in this group of patients?
I'm not sure if you guys can see me, but I don't have that information on these patients. I just sort of looked basically at straight up patency over time. And I looked at both, primary patency as well as assisted patency and secondary patency, but don't have information regarding perioperative complications per se.
Within that group that experienced a mortality during follow-up, what was the median survival? How long did those patients live before they expired? And are those the patients that maybe would be better served with a catheter?
That patient population, the patients that expired in the redo group was pretty small. So I don't know that we can make a lot of meaningful sense of those numbers. I think there were, 15 or 18 total in that group. But I did find it pertinent that most of them, especially in particular, the fistula patients, still had functional access at death. And to me, the whole question that I have here is, how do we give these patients something that's going to last them until death? My co-author on this, Dr. Sorber, set me up nicely for this conversation, but these patients have a very short life expectancy overall, 2 years on average. And so we're trying to find something that lasts a couple of years, maybe at best. A lot of these patients were deceased in a year or even less. So I think the real answer is that there isn't ever going to be a black and white answer to this question. And that I think we keep trying to make guidelines that say we should do this, and in this patient population, this is the right thing. But at the end of the day, it depends on each individual patient. It depends on their makeup. It depends on how they eyeball. It depends on what options they have for access. And I guess that's really just the point I wanted to get across with this project.
Dr. Velasquez asks, she says, great job. I may have missed it, but what was the time from creation to AV fistula use? So did you look at maturation?
I didn't look at that, but I did look at how many patients that are still living had abandonment of access at 3 months, because I figured that was a pretty good marker of that access either never matured or just never was really that functional. And out of 70 patients that were still alive at the end of the study period, only 5 fistulas and 3 grafts were abandoned at 3 months, which I thought was actually pretty good. To me, that means that there's some amount of use that the rest of those access are most likely getting over time. Now, specifically, how long did it take to get to that use? I don't know the answer to that. I guess another thing that I've kind of learned in doing this project is I've always thought about how do we decrease catheter time in this patient population as being sort of one of the primary drivers of what our decision-making is. But I've found a lot of literature out there that says that decreased catheter time doesn't necessarily lead to improved survival in this patient population. So I don't know if that is, as important as we need to make it.
One final question. As I approach my 50th birthday, I'm not quite there yet. Calling people 65 years old as elderly increasingly bothers me. Did you pick that age cut point a priori, or did you explore any older age cut points? And was there an age beyond which we really need to rethink how we take care of these patients based on your data set?
As far as I can tell, there's a lot of literature that uses 65 and there's a lot that uses 75. And I went with 65 just because you did mention there are multiple institutions involved with this, but all of these fistulas were actually performed by a single surgeon at a single institution. The authorship is just kind of from all over. So this is a small patient population. I chose 65 because there is quite a bit of literature that uses that as the definition of elderly, so to speak.
So I wanted to be as consistent as possible. I did, look at how many patients we had over the age of 80. There were actually 45 patients total, 25 in the primary access group and 20 in the redo access group that had fistula or access placement in the study over the age of 80. Obviously, that's way too small of a number to make any meaningful information out of. So we stuck with 65 for this.
Well, we have more questions, but unfortunately we're out of time for this talk. I'd like to congratulate you on this topic and thank you for bringing it to VESS for presentation.